Okay, so we're now going to do a PA hand. So still going to have a 10 by 12 cassette. Going to have my patient put her hand, we'll do it PA. And I'm just going to move my cassette so that the long axis is going with the long axis. You can turn your tube to follow. Open up your collimation, make sure the central array is in the center of the film. So that's just making sure that you're aligning with the marks on your IR, and you want to be centered at the third MCP for this. Make sure the patient keeps their fingers nice and spread apart. Just here. Be mindful of that shadow of the thumb. Make sure your collimation is open up far enough to include it. You should also be including 1 inch of the distal radius and ulna. Place your marker on the lateral aspect of your patient, GP. You're going to measure right through your central ray, so right through that third MCP joint. Give the appropriate technique, and then you ask your patient to hold still and click. We're then going to go on to an external oblique for the hand. So for this, you guys can use a positioning sponge if you want. You're still going to be centered over the third MCP. Just start, keep that fifth one down, keep the fingers spread apart a little bit. Just can move everything to keep it aligned. Actually, let's just have Libby move her hand up. Keep the fingers separated, long axis of the film. You still have your marker. I could probably now collimate a little bit side to side. Oops. Make sure your marker stays in the anatomy. You'd measure through your patient's hand for this, and then make sure your patient has GP, a marker. Ask them to hold still and click. Now, an alternative for an oblique for your hand that you guys might see done out in clinics sometimes is going to be forming a loosely letter C and just having your patient rest their hand down like this. You guys will see this done out in clinic. And is it acceptable? Yes, based on your clinical site. Some of the radiologists don't mind that you do it this way. The only downfall to when you do an oblique this way is what happens is you're not keeping the entire finger parallel to the IR, so you can end up with some distortion of each individual phalanx. So that's the perk to using the sponge, to make sure that the fingers stay parallel to the IR. However, Bontrager and your positioning packet do also show an oblique this way, so it is acceptable for you to do whichever you prefer. And then the last position that we're going to do for the hand is going to be a fan lateral hand. So for this, you want to have your patient roll all the way up so their wrist is in a lateral. You can have them touch their first digit to their second digit, and then you want to spread their fingers apart. Some people are going to be able to do this better than others. You just want to make sure the fingers stay nice and parallel. The wrist is in a nice lateral, so the fingers are in a lateral. And then the last thing I do is have them separate those fingers a little bit. Some people will squeeze their soft tissue together so much that it ends up looking like the distal phalanx of each digit are touching each other. So give yourself a little space. You have your marker. Make sure you're including 1 inch of the radius and ulna. When you do your collimation, make sure you're including the shadow of the thumb within your collimation field. Give your patient GP. Measure right where your central ray is going. For a lateral, it's going through your second MCP. Ask your patient to hold still and click.